half of approved cancer drugs don't have proof they extend survival for any of their approved uses. We're spending enormous amounts of money on drugs that we don't really know how much they're actually going to help patients.
The primary motive of a pharmaceutical industry is to generate profits for shareholders. There can be pressure to move clinical trials through quickly and approve medicines on perhaps uncertain evidence because there's massive financial forces behind that.
If they become sick, it doesn't only affect the patient, it affects the whole family.
It was very frightening. Really, in hindsight, he would have been better off not having that second line of treatment.
It's quite simple. If you give lower dosages, there's less revenue. I believe that the role of clinicians and researchers is to try to focus on the needs of patients. And sometimes these needs collide, and it can create a storm.
I'm Michael Coven. I'm Stella Coven. And I'm gonna jump backwards. And what are you gonna do? I'm gonna twirl around.
He loved taking videos of them.
Go! I'm gonna be doing...
Even though what would be the most, perhaps, unexciting thing.
The second thing I'm going to be doing is a handstand.
Something fell out. What is that? I wonder what your birthday present is.
It's for the Taylor Swift. I want to a 9-World tour.
My late husband had a very aggressive cancer. From the time of his diagnosis until his first treatment, his health was really deteriorating.
In 2014, Rachel Coven's husband, Ken, was diagnosed in his late 40s with adenocarcinoma. In his case, a cancer that developed at the junction of his esophagus and stomach. After a successful round of chemotherapy a year later, the cancer spread to his brain. His doctors tried a second round of treatment.
He ended up getting an infection in his intestines and spent several weeks in the hospital. It was very frightening. Really, in hindsight, he would have been better off not having that second line of treatment.
After a 16-month battle with cancer, Ken died in 2016 at the age of 49.
There are so many happy memories in here, and so many fun things that we did together as a family. I wanted the kids to have a book of photos and memories of their dad. My dad loved my mom. My dad was brave. I love you. My dad loved me too. My daughter has said, "Mommy, I wish Daddy picked the last few months just to focus on us and not focus so much on treatment." He missed out on a lot of the day-to-day things of just being at home and just enjoying what little time he had left. Science in general does a really good job of quantifying time to progression of disease, time for survival, but they don't do a good job describing the quality of that time within someone's life.
Canadian Tire.
It's Canadian Tire Center. It's in Ottawa.
We're going to give you the same dose of TCAM we did last time. Actually, we're going to go up a little bit on this, but we're not going to add the second drug in now.
Okay.
And we'll see how this one goes. I suspect it'll be just fine with it.
Dr. Chris Booth was Ken Coven's oncologist. He believes that some cancer drugs are being rushed to market.
The cancer research ecosystem and the regulatory system has tremendous pressure to move clinical trials through quickly and approve medicines on perhaps uncertain evidence because there's massive financial forces behind that.
Over the last couple of decades, the median number of people in trials for cancer drugs seeking to win approval has shrunk dramatically.
One of the advocacy initiatives that we've launched to try to tackle some of these issues in the last couple of years is called Common Sense Oncology. And this is really a global grassroots coalition. We want to raise the bar and be very clear that we're identifying treatments that make a real difference in the lives of patients. And you'll get the one drug, which we're doing today, plus the new drug, probably about half the dose of the new drug. there's a growing recognition that perhaps some of these treatments are not as helpful as we might expect or hope, and certainly not as helpful as patients deserve. Could they be taking away quality of life and making people sick without actually helping them live longer lives?
There's a long history at the FDA leading up to how they regulate cancer drugs today. In the 80s and 90s, the FDA was under heavy criticism from HIV activists for not moving quickly enough on getting potentially life-saving HIV drugs to the market when HIV was a death sentence. And that led to a new process called accelerated approval, where the FDA essentially would approve drugs based on preliminary data that hadn't yet been fully proven. So over the last 20 years, the FDA has heavily employed this accelerated approval process to approve many cancer drugs. They're approved often either on tumor shrinkage alone or on this metric, progression-free survival. Some people say that's very misleading because it's actually not survival. It's mostly, does the drug delay the growth of a tumor on a scan? As it turns out, that metric is not as predictive of actual survival. The drug companies and many patient advocates that are allied with them say, we need these drugs quickly and need the FDA quickly, and patients can't wait. What our reporting found was that fully half of approved cancer drugs don't have proof they extend survival for any of their approved uses. We're spending enormous amounts of money on drugs that we don't really know how much they're actually going to help patients.
In the US, private insurance and programs like Medicare often cover most treatment costs for cancer. In countries like India, where the vast majority of patients can't afford treatments that can run into the high tens of thousands of dollars per year, doctors are experimenting with lower doses to treat patients. For patients, this would mean less time in treatment and greater cost savings. For pharmaceutical companies, it could also mean less revenue. In 2024, Hemant Prakash Champanaka discovered ulcers in his mouth. He kept them a secret from his family, fearing that he couldn't afford the cost to treat them.
छोटे से ये रहेगा, जख्म रहेगा, इसके लिए मैं इन्वर्ट करके 9 महीना गुजर गया था. उसके बाद में मुझे मालूम पड़ा कि मैं चेक किया, हमारे डॉक्टर लोकल डॉक्टर से वहाँ से चमड़ी निकाल के चेक किया. उसके बाद में मालूम पड़ा कि एक कॅन्सर आहे. इंडिया देशामध्ये गरिबी एवढी आहे की भरपूर लोक गरीब आहे आणि ते करू शकत नाही हॉस्पिटलमध्ये, म्हणून ते लपून ठेवतात. पण आपली कॅपॅसिटी नाही आहे की आपण हे देऊ शकतो. आणि आपली फॅमिलीचं पुढे आपल्याला पुढे बघायचं, मुलांचं शिक्षण आहे, घर आहे, घराचं भाडं आहे, सर्व पोचायचं, म्हणून ते लपून ठेवतात.
Champanaka's doctor agreed to waive the fees for the medication. He prescribed a treatment that, on paper, shouldn't have worked, 1/6 of the recommended dose.
आता फर्स्ट डोस मला दिला तर मला जरासं रिलॅक्स वाटते. पहिले इथे पेन होत होतं, आता पेन होत. काल 5 yesterday आहे ना, तर इकडे पहिलं पेन होत होतं, नसा असं जाम वाटत होतं, हात दिसला होत नव्हतं, असं मान पण खराब होत नव्हती. आता जरा पहिल्या डोसपासून मला तर फ्री वाटते. आता इकडे तर पेन कमी झालेलं आहे, म्हणून मला असं वाटतं की या औषधाने मला चांगला इफेक्ट पडून चांगलं होईल असं वाटते मला.
Champanaka is not alone. Dr. Kumar Prabhash works at Tata Memorial Centre, which registers 50,000 new cancer patients every year. 25% of their patients have head or neck cancers, yet few could afford a full dose of immunotherapy.
Some of the drugs are very good, and we know they are very useful for our patients. And it is very disheartening for clinicians to see that I wish this treatment was there for this patient. These cancer patients, if they become sick, it doesn't only affect the patient, it affects the whole family. So we finally took the lowest dose which was there and which was where the patients had responses in the phase 1. We thought that is something which majority of our population can afford it.
In a clinical trial, Dr. Prabhash and his team added a low-dose immunotherapy to the standard treatment for head and neck cancer in India. The combination more than doubled the percentage of patients still alive 1 year later. In a country where there are often more stories about negative healthcare outcomes than positive ones, doctors may have found a new solution born out of desperation.
Almost 3 to 4% of our patients could take this full-dose immunotherapy, and it looks like almost 60% of our patients can take the same treatment if the dose changes. Almost 2/3 of cancers is happening in developing country. It may end up saving billions of dollars. It may end up benefiting hundreds of thousands of people.
2,500 miles away in Tel Aviv, Israel, Dr. Daniel Goldstein, an oncologist and founding director of the Center for Cancer Economics, published a study showing that lower dosing of just one drug could save $825 million a year in the US alone, while still being highly effective.
We have a tremendous problem in the whole field of cancer care, where the expenditures are just increasing and increasing. Sometimes those costs are getting passed on to patients. We're actually funding many drugs that really are what I would say are poor value and not cost effective. One of the things that I focused on over the past 7 or 8 years is trying to figure out if there are ways that we can reduce the expenditure but maintain the health outcomes and the effect. So can you give a lower dosage? Can you use the drug for a reduced amount of time but still get the same health benefit? We also tried to implement it here in Israel, but when we started to implement it, there was tremendous pushback, and it led to a major storm here in the process of policy implementation. The manufacturers do not like research work or policy work related to using lower dosages. It's abundantly clear. It's quite simple. If you give lower dosages, there's less revenue. The primary aim of a manufacturer is to increase revenue for their shareholders. We showed that you can use essentially 25% less drug, get the same output, and save tons and tons of healthcare resources.
So we found in our reporting that over the last 2 decades, the median initial price of a cancer drug in the U.S. has quadrupled. That comes even as there is no correlation particularly between those prices and whether they improve survival or not. Some of these so-called immune therapy drugs, which are some of the most important targeted cancer drugs approved in the last 10 to 15 years, are some of the biggest sellers in the world. If these ultra-low doses turn out to work, it could be akin to getting HIV drugs to Africa for the first time, allowing a large segment of the world that don't have full access or can't afford some of these life-extending drugs now will finally get access to them.
Since getting the reduced dose, Shampanakar is recovering. His tumour shrank 80% and he was able to undergo successful surgery aiming to remove the rest.
आता मेडिसिन घेतलं त्याने मला फरक पडलेला दिसतोय, म्हणून मला आशा वाटते की मी याच्यातून बरा होईल आणि चांगला ठणठणीत घरी राहील. देवकृपाने इसे सर्वांना ट्रीटमेंट भेटून दे.
Stella and Michael had a game that they played with their dad that was called Love You Infinity. And every morning, whoever got up first had to run and say to the other person, I love you infinity. It was a competition every morning. So when I asked them what they thought would be a good thing to put on their dad's gravestone, they said, love you infinity. So that's what we did. His memory lives on in all the hard work that's being done to help patients and their families really live the best quality of life at the end of their life. And that patients and their families who are in similar situations that I was once in can hopefully make better, more informed decisions than perhaps we did.